Welcome.
Prostate cancer, with the road to recovery. My name's Jason, and I have advanced prostate cancer that has spread to my bones. If you're joining us for the first time, I'm sharing my cancer experience. In our last episode, we discussed the diagnosis and what it meant. Today, we're diving into the specifics of stage 4 metastatic prostate cancer and what it means. Let's talk about it. So what does metastatic mean? Well, nearly 70% of prostate cancer diagnoses are caught early enough that the cancer is confined to the prostate. That's because it's generally a slow-growing cancer and it's found early. When it's found and diagnosed early, it's highly treatable. In fact, the 5-year survivability for most non-metastatic prostate cancer is almost 100%. However, once the cancer cells get out of the prostate, when they break away from the primary tumor and they travel through the body, they land in new sites and they establish new tumors. This is what we call metastasized prostate cancer, which is what I have. The website prostatecancerfree.org has some very detailed information on staging of cancers, and I recommend you take a look at that when you get a chance. Again, prostatecancerfree.org. The Cliff Notes is that if it's no longer contained completely in the prostate and has possibly spread to the seminal vesicles or local lymph nodes, it may be stage 3 or stage 4. If it's spread to another organ or to the bones, it's stage 4. So while stages 2 and 3 can be intermediate and high risk, stage 4 is, to quote one of my doctors, beyond high risk. Basically, once prostate cancer has established new tumors at distant sites, the 5-year survivability rate drops to around 30%, according to the National Cancer Institute, with a further drop at 7 years down to 10%. I'm 52 years old. That means statistically I have only a 10% chance of making it to 60. While that may seem bleak, today is September 2023. In fact, September 1st, 2023. I was going to wait to record this, wait till Sunday to record this, but I'm actually feeling pretty good today after they moved my third treatment up to earlier in the day, and I'm feeling a little better tonight, so I'm just going for it. Anyway, today is September 1st, 2023, like I said, and it's just 6 years after a 2017 study on metastatic prostate cancer that found the 1-year survivability rate was only 35%. The 3-year was a little over 10%, and there wasn't really a 5-year survivability rate. That is, well, those numbers aren't good, and that was just 6 years ago. My odds are better already, better now. I mean, in 2023, with a 5-year survivability rate of 30-ish%, that's not bad compared to 6 years ago. Cancer treatment's come a long way, and it continues to better the odds. That's important. It's important to understand that the prognosis for diagnosed cancer patients is constantly changing, and generally for the better. I'll get past the 1-year mark, and by then my 5-year chances will improve, then the 2-year mark, and so on. As I go through this, my odds get better. Eventually, I'll be looking at a 10-year survivability rate that's higher, and I can set my sights on beating that one. The challenge is, the gravity of the whole stage 4 diagnosis is that while prostate cancer confined to the prostate is generally curable, once it's established new tumors, such as in the spine, treatment is now generally, not always, palliative rather than curative. But again, that is constantly changing. In the 2023 ZERO Prostate Cancer Summit, they indicated that some stage 4B, 4 Bravo prostate cancer cases have been curable with aggressive treatment programs. And there's several aggressive treatment programs. I vaguely recall one of them was called PEACE, PEACE-1. There was a STEAM. And what they're finding now is different than what they were doing even 5 years ago. 10 years ago for sure. And that is the protocol called for, hey, if you have cancer and it's metastasized, start you on, for example, hormone therapy. And then you just do that, just one of them, until it becomes castration resistant. And then you do another treatment, or you do radiation. And wait and see how that goes, and then you do hormone treatment, and then you do chemo, and you do all these separately under the idea that, well, you're going to prolong your prognosis. You're going to prolong your life by staging it out, by treating it a little here, a little there, a little there. And they're finding now that's not how it works. It's better. Well, I'm not a doctor, so what I am reading is that it sounds like they think it's actually better to go for it with a more aggressive, let's do multiple treatments at the same time, and that's what we're going to talk about. One of the websites that I recommend is zerocancer.org. There's a lot of great information there, and that's where I'm getting some of this information. I'm going to several different cancer websites, so I'm going to talk through these on all these episodes. But all these stats aren't really useful for every one of us. And what I mean is, when I say my odds are, I don't actually know what my odds are, right? Because there's so many things that play into my odds. And if you're as a listener are going through this or recently diagnosed, these aren't necessarily your odds. These are just statistical, historical odds, and we don't even know all the data of exactly how old they were, what health were they in. They're finding that there's genetic, ethnic, dietary, all these things impact the prognosis. So our individual prognosis depends on age, general health, what our secondary symptoms are, how the cancer responds to treatment. Like I said, all the genetic considerations, and so many other factors. So we can't rely on looking at these stats and saying, oh, this is my prognosis. That's not true. So anyway, back to metastatic. It doesn't just mean it's spread to the bones like mine did. While prostate cancer does favor the bones, according to the Mayo Clinic, it can spread to any part of the body. But it's still just an organ tissue cancer and tends to favor spots like the lymph nodes, the lungs, and the liver, secondary to the bones. It prefers the bones above all for some reason. I don't necessarily understand the mechanism, but it's important to get scans that look for METs to the soft tissues as well, not just the bone scan, the CT scan with contrast to the bone scan. But there's another scan. Getting that extra scan is something that changed my prognosis and treatment. When we first did the CT contrast scan and the nuclear medicine bone scan, those both showed METs to my spine, and METs is short for metastasis or metastatic sites. And one of them showed a MET to a rib, my 11th rib on the left side. So with that diagnosis, saying, hey, it's spread to multiple spots, we're going to attack it with hormone therapy. We're going to use two drugs. One's called Lupron and one's called Zytiga. And we're going to do radiation treatment. We're going to do radiation treatment to your prostate. We're going to do radiation treatment to your spine. And we're going to do chemo. And yeah. So in fact, that protocol I think we were following was the STEAM protocol, or PEACE, P-E-A-C-E, PEACE protocol. But fortunately, my radiation oncologist ordered one more scan, and it's called a PSMA PET scan. Now, the Tri-Cities, I've told you I'm here in the Tri-Cities of Washington. The Catholic Medical Center now has a PSMA PET scan, thanks to the efforts of my radiation oncologist who got one put in here recently. I don't know how recent, though. I'm hoping to get him in here, and we'll talk about stuff like this because he's got a lot of great information to share. So this scan, if you remember, I talked about my nuclear medicine bone scan where they injected me with about 25-something microcuries of technetium-99. On my PSMA PET scan, they injected me with 12-point-something, I think 12.6 millicuries of fluorine-18. Now, fluorine-18 has a much shorter half-life than technetium, or just about many isotopes that they could use. It's and this is pulling this from memory, 1.18 or 1.81 hour half-life. So it takes a big dose because you have to inject it, and it has to have time to work through your blood system, work through your system, and uptake into any cancer identified areas. It tends to favor cancerous cells. That fluorine 18 is, anyway, we're going to get into all the specifics of the PSMA PET scan on a future one. Basically, you have to get so big of a dose because that half-life is ticking away. And so you have to sit there for an hour waiting for it to uptake into your system. So now it's almost half of its strength. And then you sit through the PET scan, and that's 35 minutes of laying there motionless. They did give me headphones. I listened to, who did I pick? So I wanted something melancholy. I picked Milky Chance. Anyway, I sat there for 35 minutes for the scan. So it's as time is going on, that dose is decaying, right? But I am getting way off topic here. So anyway, we're going to talk about that specific scan in a future episode, hopefully with a radiation oncologist, so there's not any guessing. But why it's important is because it will show anything that is cancerous. It's more likely to. So my PSMA PET scan, even though there was a concern on the rib and they didn't have any idea if there was anything in the soft tissue, this will show if there's anything in soft tissue. And what we found was the only metastatic site of concern is the L1 vertebrae of my lumbar. And if you remember me talking on the last episode, I completely mangled the lumbar or the spine. Like it turns out the S is below the L's, and which is your S is your tailbone, your L's your lumbar, and above that is the T. And then above that is the C. Anyway, doesn't matter. But with that diagnosis that it was only in my L1 vertebrae, my oncologist and I decided to take chemo off the plan for now. And we're going to see how I respond just to the ADT and radiation treatment. And like I said, for the ADT, I'm doing a combination of Zytiga and Lupron. And my Zytiga is a 1,000 milligrams, 4 250 milligram pills every morning on an empty stomach. And the Lupron is a shot that I get once every 3 months. Now, the protocol for the Zytiga, because it has a tendency some of its side effects are that it raises cortisol levels and causes other problems, which aren't good for trying to fight cancer. So they also prescribe prednisone with the Zytiga, which has been immensely helpful because I started the Zytiga back on August 11th, and long before I started the prednisone. And for whatever reason, my script didn't come through for that, so I was on the Zytiga, and then I got the Lupron shot, and then, I was only making it... I don't even know how many hours into a day before I was just drained already, just weeks into treatment. And I started the prednisone, and that helped. That helped the energy levels. So I've seen in the cancer forum, some people are saying, hey, I don't have any strength. I don't have any energy. I'm on this Zytiga. I'm doing this. What's going on? And I always ask, hey, is there a prednisone? Did they prescribe you a steroid to help? And often they didn't. So talk to your doctor and see if it's right, because it's not right for everybody, right? But if you are able to do the protocol with the Zytiga and the prednisone, that has helped me. Back to my diagnosis. I keep pausing my little teleprompter thing here. I have to reset where I'm at. So with the diagnosis, my oncologist and I decided to take chemo off the plan. So we're just doing the ADT and the radiation treatment. And I'm going to do an episode dedicated to each of the treatments because there is so much information there. There is way too much to talk about here. My goal with these episodes is to keep them about 25 to 30 minutes, mostly because after 30 minutes, my camera stops recording. But the challenges will be setting up a future episode. Anyway, let's get back on track. Let's talk about symptoms. Now, this was something, everything that I go back and revisit, this is what I revisit. I'm like, well, I wish I'd have, and I keep playing that over and over and over in my head. I wish I'm going to say this out loud, mostly for my own benefit, because it's important that I vocalize this to help bring this home. I need to stop worrying about what I should have done and focus on the treatment going forward. It doesn't matter. I cannot go back and change the fact that I waited, that I didn't recognize these symptoms. I can't change that. So I have to quit worrying about that, because that stress, the cortisol level building up, the inflammation from the stress does not help fight cancer. It actually is counterproductive to that. But let's talk about these symptoms. So once a tumor has symptoms of metastatic prostate cancer, so once a tumor has established itself outside the prostate, you may not have a lot of new symptoms. The basic ones are vague and not very helpful. Yeah, you might have some bone pain, and mine was a dull ache in my lower back. And that's a stretch to say that it was even a dull ache. Some days it was, most days it wasn't. So some bone pain, fatigue, and a general feeling of being unwell. And I pulled that off a cancer website. A general feeling of being unwell. Well, guess what? I'm 52 years old. I generally don't feel well every day anymore. I thought this is what it felt like to be 52. Didn't know might be because I had cancer. So what I found was that I only recognized the symptoms after the diagnosis. I look back and they say, talk about your urine flow, how often do you need to pee? Do you have any bone pain? And I think back, I'm like, oh, well, yeah, I guess I didn't slowly notice a change in, my urine flow, my urgency. I did slowly notice a change in how often I needed to pee, but not, and how hard it was to get going. But not in the moment. It was just, you don't notice small changes. The whole frog in the water thing, right? I was struggling with fatigue, and I was not feeling well. I had some lower back pain, and it was getting worse over the last couple of years. But also, in 2021, I was in the hospital for a month with COVID, and I've been struggling to recover from that. The weight gain, the stress, all of these things, I just rationalized away my symptoms. So it's what I want you to take away from this is don't rationalize away your symptoms, okay? So it was getting back on the bike in March, trying to get rid of some of this COVID weight. I wanted to lose some weight. I wanted to kick this fatigue in the butt once for all, because I keep trying to come back, and then I get worse. Then I try and come back and get worse. I got back on the bike, and there was some discomfort. So like I did with the lower back pain and the general fatigue, I rationalized the discomfort down there as too much on the bike too soon. And so I just started doing every other day. Eventually I went to the doctor, and we started eliminating other causes. My doctor referred me out to a urologist, and then we started down the diagnosis path and got my diagnosis, and now we're headed down the treatment path. So looking back, I don't know that I'd have noticed anything different. Like, given all the exact same situations, I'm not sure I would have noticed, unfortunately. It's tough to make the leap from my back hurts to it must be cancer. So I don't know. I guess this is a message to others to make sure you are considering all possibilities, and that you give your doctor all the information so they can put the pieces together. Let them eliminate things. It's easy to get a screening. It's easy to get a scan so that you can eliminate things, and they can say, oh, you were worried for no reason, right? It's better to hear that. So when you answer the questions, be honest, and don't, I keep using the word rationalize, with inner thoughts like, well, they probably mean unusual back pain. Are you having any back pain? That's what would go through my head is, well, they probably mean unusual. Right? I have normal back pain. I'm 52. I have normal back pain, but that's not what I vocalized. I vocalized no. So The message is tell your doctor everything about how you feel, okay? Let's talk about treatment options. For metastatic prostate cancer, I've already hit on some of this a little bit just because I get on a train and I babble. So currently the treatment protocol states that once it's spread outside the prostate, surgery really isn't an option. I've got a whole episode planned on surgery versus radiation. We'll get into the details there, but for now, unless there is some other reason to do the surgery, like to correct a specific symptom, got bladder issues or something, from the prostate cancer, there's no reason to remove the primary tumor. That was tough for me to wrap my head around. I'm pretty sure I frustrated my doctor on this topic, because I recall I said that if I used an analogy with cars. I said, if you know there's metal debris in the oil pan that's getting picked up and circulated through the engine block, causing problems in your valves and your lifters and your cylinders, wouldn't you remove the oil pan, get rid of the metal debris, flush the block, then put everything back together? Well, we'll get into the specifics on another episode, but basically it's not worth the risk. It's not like removing an oil pan, right? And an oil pan just unbolts and you're not really affecting anything else. Now, if your oil pan was one integral part that included your crankshaft and your oil pump, I like this analogy better and better. If it included all of that and it was a more complicated, then it would be a good analogy. But when you drop your oil pan, you're not likely going to cause issues with your crankshaft and your oil pump. That's where the analogy falls apart. All right. There's more complicated risks with prostate surgery. The goal with surgery, the whole reason you would do surgery is to remove the tumor to prevent metastasis. Once it's moved on to other spots, the risks with the surgery outweigh the benefits, generally. Talk to your doctor. So for metastatic prostate cancer, we're looking at two main things. Remove the fuel from the fire and douse the fire. Testosterone is the fuel for the fire. The goal is to starve the cells, then kill them off. Healthy cells and even cancer cells rebuild after damage, as long as they have the fuel to do so. Fuel for healthy cells include oxygen and nutrients from food that are broken down into activated molecules, which are processed by the cells as energy. By the way, I had to look all that up. You know, from the last episode, I did not take biology in high school. But things like cruciferous vegetables and healthy proteins all provide the energy for healthy cells. Prostate cancer cells, on the other hand, use testosterone for their fuel and have learned to thrive without the oxygen and without the normal cell nutrients. In fact, they go right for the crack. They go straight for the testosterone, which is a super high amount of energy, right? This is what makes the combination of hormone therapy and radiation treatment so effective. You starve the cancer cells while eating healthy to support your healthy cells. Then you zap the cancer cells, which don't have fuel to rebuild, while your zapped healthy cells are able to recover from the radiation damage, the damage due to radiation. Because the radiation is going to treat your cells. Doesn't care whether they're cancer cells or whether they're healthy cells. The goal is to hit the tumor and hopefully your healthy cells could rebuild. So the radiation treatment is generally done over some number of doses, administered 5 days a week till the cancer's been zapped enough to hopefully be killed off. For me, they determined I need 28 doses, which is about 5.5 weeks of treatment. And that's just for my prostate. There's another 5 doses for my spine. There's a bit of a setup to get ready for treatment, including getting tattoos. Yep, I got tattoos, 3 of them. So what they do is they use a single needle with ink to mark you in 3 spots to externally identify to the lasers where your prostate is. They put one on my left side, one on my right side, and one under my belly, all right around the belt line. Not the normal skinny guy belt line, but the fat guy belt line. It's important to make sure the machine is lined up right every time because you don't want to overzap your colon or your bladder. And that's tough because where your prostate sits, it's tough to target only the prostate. but there are things that can be done to minimize residual damage around surrounding tissue. When I show up for treatment, I have to show up with a full bladder and an empty colon. So the empty colon makes sure that there's not stuff pressing the colon tissue up against my prostate. And the full bladder is to provide water shielding from the to protect the bladder from the effects of radiation. And that's super, super important. And they check the cameras. I lay on the table. They check the cameras. As long as I've got an empty colon and a full bladder, then I can do the treatment that day. So we'll go into immense detail, gross detail, on the radiation therapy in a future episode. But it's not energy that's like a bubble. That's isolated to the target area. It's focused on the target area. But as the energy from the radiation travels through the body, it continues to release and dose surrounding tissue. And you have to have an area so that you're getting the target area, which is why it helps to break it up into multiple sessions. Now, there are more treatments than just hormone therapy, than just ADT and radiation. There are options for chemo, immunotherapy, ablation treatments like using heat, cold, or even electricity to stick a needle in you and use electricity to destroy cancer cells. I recommend asking for an integrative oncologist. I think that's important. I think making sure that you're getting someone that's on top of all the current treatments is super important. It's important that you work with your doctor, that you talk to them and determine the right treatment plan for you. This is not something you go to social media for and say, these are my symptoms. This is my diagnosis. What's my treatment plan? It does not work like that. There's not a one-size-fits-all plan. Work with your doctor. Well, I think we're going to wrap that up here. I appreciate your time. Thanks for listening to episode 2 of Prostate Cancer, The Road to Recovery. Whether you're watching on YouTube or listening on Spotify, I want you to know that I appreciate your time. I hope you got some actionable information and insights. And remember that every case is unique. Keep fighting. I love you all.